हाँ हाँ हाँ
तो
हाँ
क्या बोलते हैं मोस्टली, आप ध्यान दिए कभी?
हाँ गुड। आप जो भी, मैंने ऐसे ध्यान नहीं दिया है।
अच्छा अच्छा,
आप
कोई बात नहीं।
जो शुरू का बोल सकते हैं ऐसे कर। देखिए ऐसे गुड मॉर्निंग कह रहे हैं, वैसे आप भी बोल सकते हैं।
Good morning. Today seminar is biomarkers of sepsis, and for these biomarkers we have to understand this in just like introduction. First, we see the introduction and the role of biomarkers, list of biomarkers, clinical significance of biomarkers, and future sepsis biomarkers combinations, and last in the conclusions. So first, for biomarkers, we have to understand what is the sepsis. Um, uh, Sepsis is a inflammatory immune response triggered by an infection, and it is a life-threatening condition that arises when the body responds to infection. And it's when a person is in sepsis, the sepsis is causing injury to tissues, organs. When a person is in sepsis, some signs and symptoms appears. The person getting fevers more than 100.4 degree Fahrenheit, or he is in hypothermia, and hypothermia defines the temperature is below 96.8 degree Fahrenheit, and his heart rate will increase, and that is more than 90 beats per minute. His breathing rate is increased, and mostly more than 20 minutes, 20 per minutes, and he is in confusion. And mostly some in sepsis, some bacteria they infect particular organs like lungs, kidney, heart. So some related organs specific symptoms come. That is the if the person infection is lungs, then he is cough with pneumonia, and like kidney infection, then is kidney infection, painful urination, and so we have for this sepsis some steps in sepsis like sepsis, severe sepsis, and septic shock. So this sepsis, to understand sepsis, we have to understand what is the SARS. See, SARS means systemic inflammatory response syndrome, and this SARS defines is temperature is more than 100.4 Fahrenheit, or temperature is below 96.8 Fahrenheit. Respiratory rate is more than 20 per minute. Heart rate is more than 90 beats per minute, and WBC count is more than 12,000 or less than 4,000, and his bands percentage is more than 10%, and this bands is bands define this is a immature neutrophils, and in case of any infection or in sepsis, the bands is increases more than 10%, and is partial pressure of CO2 below 32 millimeter mercury. So this SARS, we know about SARS. Then this first sepsis is these two times of SARS plus the person confirmed or suspected infection, and this sepsis after severe sepsis define sepsis plus signs of organ damage is any organ may be damaging, and if any organ damaging it leads to person in hypotension, and hypotension defines the systolic blood pressure is less than 90 millimeter mercury, and that in bodies lactate level is increased, and that lactate level is more than 4 millimole per liter. And after this severe sepsis, the person goes in septic shock, and the septic shock defines severe sepsis with persistent. This sepsis, though severe sepsis, is present persistently, and this defines signs of in organ damage plus hypotension plus lactate level is more than 4 millimole per liter. So first we see the definitions of sepsis and these related terms. Systemic inflammatory response syndrome. What is this systemic inflammatory response that occurs regardless of cause? The cause may be infective or non-infective. This source it can be with infection or without infection. Maybe non-infective and some internal core body temperature increases due to some reason. And sepsis is a systemic inflammatory response to infection, and we also see in table the definition of this sepsis, severe sepsis, and septic shock. So in severe sepsis is associated with organ dysfunction and hypoperfusion abnormality or sepsis induced hypotension. And the septic shock is a subset of severe sepsis and is defined as sepsis induced hypotension persisting despite adequate fluid resuscitation along with the presence of hypoperfusion abnormality or organ dysfunction. So in 2001, some updated diagnostic criteria came for SARS, and some parameters given to understand what is the SARS. So general parameter, mostly general parameters like fever, hypothermia, heart rate, and heart rate is more than 90 beats per minute. Tachypnea is more than 30 beats per minute. Altered mental status, significance, edema or positive fluid balance, or hyperglycemia. In general parameters define SARS. Some inflammatory parameters like leukocytosis, leukopenia, normal white blood cell count with more than 10% immature forms, that is bands form, is more than 10%, and CRP rest is more than 2 standard deviation above normal, and this procalcitonin is more than 2 standard deviation above normal. This is inflammatory parameters. Some parameters like hemodynamic parameters like arterial hypotension or decreased systolic blood pressure, mixed venous oxygen saturation is more than 70%, or raised cardiac index. These are the hemodynamic parameters defined SARS. Some organ dysfunction parameters are arterial hypoxemia, acute oliguria, increased creatinine level is increased, and coagulation abnormality like prothrombin time, these are EPTT, they are maybe increased, and some ileus, thrombocytopenia, and hyperbilirubinemia. These are the organ dysfunction parameters. Some organs, if working dysfunction, then these parameters are disturbed. Tissue perfusion parameters like hyperlactemia and decreased capillary refill are mottling. After this 2001 this search diagnostic criteria, sepsis 3 criteria comes, and this define sepsis like life-threatening organ dysfunction caused by dysregulated host in response to an infection. And also in sepsis 3 definition is most widely used. These define sepsis, organ dysfunction, septic shock, and patient with septic shock. We already have seen the patient with septic shock is identified a clinical construct of sepsis with persisting hypotension requiring vasopressors, having serum lactate level is more than 2 millimole per liter despite adequate volume resuscitation. And some we for understanding is this sepsis three diagnostic criteria, the subclinical criteria we see by this diagram, like a sketch diagram, to understand the sepsis and septic shock. Like if a person, if a patient with suspected infection or he is in sepsis, then we have to SOFI score, and one is Q-SOFI score. SOFI score is sequential organ failure assessment score, and was in quick sequential organ failure assessment score. And if any patient come to with suspected infection or any infection, then we have to evaluate Q-SOFI score, and if this Q-SOFI score is more or equal to 2, then we have to think that he is in sepsis, and we have to assess for evidence of organ dysfunction. If he is in sepsis and Q-SOFI score is more than 2, then we have to think that in that person any evidence of organ dysfunction is not is there. So again we assess like a SOFA score, that is a sequential organ failure assessment, and is equal to more or equal to 2. If yes is coming yes, then he is definitely using sepsis. And sepsis, after we diagnose like he is in sepsis, then we give some fluid resuscitation and some vasopressor required to maintain his mean arterial blood pressure, and this mean arterial blood pressure should be more than 65 millimeter mercury, and serum lactate level is more than 2 millimole per liters. After resuscitation, if this fails, then this patient is going in septic shock. If this Q-SOFA score is not more than 2 or equal to 2, then we have to think then sepsis is still suspected. If no, then only monitor clinical condition, re-evaluate for possible sepsis if clinically indicated. If sepsis is still suspected, then again we have to do assessment for evidence of organ dysfunction and SOFI score, and this is if this SOFI score is more than or equal to 2, then this person is sepsis, and we again see that despite of adequate fluid resuscitation and vasopressor, so these are in septic shock if this criteria is not fulfilled. If SOFI score is less than 2, then this person only we can monitor clinical condition, reevaluate for possible sepsis if clinically indicated. So by this sketch diagram we can evaluate understand how a person if is suspected infection, so we can identify sepsis and septic shock present in this patient or not. After this sepsis 6 initiative came, and this defined this is when a person came to us like he is in any infection and he become in sepsis, so we have to do these 6 initiatives before, like combination of what is this 6 sepsis 6 initiative. This is the combination of both monitoring and proactive measure that should be performed within an hour. So these 6 initiatives, first we should deliver high flow oxygen to that patient, and second thing is we have to take that person blood for culture, then and send blood culture and administer empiric intravenous antibiotics, and the fourth is the measure serum lactate and send full blood count. For fifth is a start intravenous fluid resuscitation, because if we give fluid resuscitation, his organ failure probability is less. And last is 6 commence accurate urine output measurement, because his urine output measurement is the best uh, uh, diagnose diagnostic things. We have to diagnose a patient is going to septic shock or not. So this is the urine output is the best measure. And for these biomarkers, we have to understand the sepsis and sepsis. This pathobiology. What is the pathobiology of sepsis? We have to understand. Then after this pathobiology understand, then it is very easy to understand how biomarkers biomarkers act and how we can by evaluating biomarkers diagnose that patient. So pathobiology of sepsis is the sepsis is dysregulated host immune response with a combination of pro and anti-inflammatory process that lead to organ dysfunction. And one thing is cytokines are a key signaling system in pathobiology of sepsis. Cytokines is a key signaling system, potentially lethal role of tumor necrosis factor alpha in experimental studies. The initial event that forms the pro-inflammatory response is initiated by detection of the invading pathogens. Then host immune, when any pathogens enter in body, so our host immune cells express pattern recognition receptors both on extracellular surface and in the cytocells. So, the extracellular receptors are mainly toll-like receptors with knot-like receptors found intracellularly. So these toll-like receptors is what these toll-like receptors to understand. This is a pathogen detection recognizing pattern associated molecule from pathogen. This PAMPs is from pathogens and damage associated molecular patterns, that is DAMPs, and this is from damaged endogenous cells. These two are the PAMPs and DAMPs are toll-like receptors. Then overstimulation of toll-like receptors by these dams propagate the inflammatory response in sepsis, detect pathogens, and invade cytocells, leading to formation of inflammasomes for the further production of inflammatory cytokines. Uh, this promotes inflammatory state with activation of leukocytes, complement and coagulation pathway to endothelial, cellular and cardiovascular dysfunction leads to sepsis. So for any pathogens when enters in the body, so we see these toll-like receptors activated, and these toll-like receptors provide this is PAMPs and DAMPs. This PAMPs is from pathogen and DAMPs is when this pathogen damages any endogenous cells, then this DAMPs release. And this overstimulation of this toll-like receptors by DAMPs is propagate inflammatory response and leads to sepsis, and some inflammasomes is production of inflammasomes, and this inflammasomes some cytokines also release, and these cytokines further leads to dysfunction of any organ and leads to sepsis and septic shock. So these infective agents are recognized by host immune cells via pattern recognition receptor, both extracellular and intracellular. With the help of this diagram, we can easily understand how this. So first, these cells also recognize the cells related by damaged host cells, and in response, the immune cells release inflammatory cytokines activating leukocytes, which in turn release cytokines and reactive oxygen species promoting the inflammatory response, which can affect host cells as well as invading pathogens. So with the help of this diagram, we can easily understand these infective pathogens when damage enters in our body, then it's infect any cells, then our immune systems activate, and these infective pathogens release this PAMPs, release of PAMPs, and these PAMPs on PAMs act on this host immune cell recognize this PAMs molecule, and also this PAMs molecule from damaged host cell is recognized, and after this the whole our host immune cells releases some like interleukin, release some interleukin and tumor necrotic factors and different kinds of interleukins, and these interleukins activate like neutrophils, macrophages, monocytes in our body, and these neutrophils, monocyte, macrophages act on these uh, mm, uh, ROS these molecules, and damages our systems organs. For biomarkers, we have already understand what is the sepsis and pathobiology of sepsis. So we can easily understand what is the biomarkers and the role of biomarkers in sepsis. So what is the biomarkers? Biomarkers is biological molecule found in blood, other body fluid, tissue, tissue. So this is a signs of normal or abnormal process or condition or disease. So this it is a biomarkers is a biological molecule, and it can be found in blood, other body fluids or tissues. And this biomarkers is a sign. It's in body is a signs of normal abnormal process or person in maybe in disease condition. So biomarker used to see how well body respond to the treatment, and also called molecular marker or signature molecule. So different types of these biomarkers we have. This like molecular biomarkers, histologic, radiographic. So in molecular, we have just had in blood glucose, some histology in my tissues. We found some biomarkers like radiographic, tumor size. This is the biomarkers, and what is the role of these biomarkers in our body? This is mostly for diagnosis. And diagnosis, what is the ruling out sepsis, identifying patients who may benefit from specific therapies, uh, follow-up response to the therapy. If we are getting some medicines for any disease, like in cancer, we are giving some medicines, using some medicines for this therapy. Uh, these medicines how work on that cancer cells. So useful. um, by these biomarkers, we can study the response to therapy for prognosis and staging and patient stratification. Different classes, in different classes, like a mild, moderate, severe. The patient depends. Patient is in mild, moderate, or severe. We can also identify by biomarkers. So some list of biomarkers in sepsis. Here is some acute phase protein like CRP, C-reactive protein, procalcitonin, and traxine free, and lipopolysaccharide binding protein (LBP). So these biomarkers are acute phase proteins. Another category like cytokines and chemokines like interleukin, in different kinds of interleukin 1 beta, interleukin 2, interleukin 6, and in these cytokines and chemokines, interleukin 6 and this MCP1 is important, because if a person get infection, so his body temperature is increased. So in like body temperature increase, he got fever, and in fever this interleukin 6 is very good cytokines biomarker. Second, third is cell surface biomarker like soluble CD, cluster of differences. This is CD14. This is also known as Preceptions. This is very important biomarkers. Neutrophils, CD64, and CD163. Another is receptor markers like VEGF, vascular endothelial growth factor, some soluble VEGF receptor, and soluble urokinase plasminogen receptor, this is SUPAR receptor, and STRM1 receptors. This some coagulation biomarkers is also like APTT, activated partial thromboplastin time, protein C receptor thrombomodulin, endothelial damage biomarkers like heparin binding protein, E-selectin, neopterin, and this vasodilation biomarkers as copeptin. This is the copeptin is a ABP precursor. For cell damage, the biomarkers are this microRNA or microparticles. These are the new biomarkers came. And for cell repair is procollagen 3 amino polypeptide. So most commonly biomarkers in sepsis used is procalcitonin, CRP, there is C-reactive protein, interleukin 6, soluble trigger receptor expressed on myeloid cells, as is STRM1, CD64, lactate, neutrophil to lymphocyte count ratio. This is very important biomarkers, neutrophil to lymphocyte count. When we got complete blood cells count, here mentioned there is a neutrophil to lymphocyte count ratio, this SUPAR. So some biomarkers on the basis of their actions in our body define like which ideal biomarker, some best biomarkers like procalcitonin, Preceptions, CD64, SUPAR, and STRM1 are the best biomarkers. This test is utility, performance, and validity of future biomarkers before implementing them into routine clinical care. So in routine clinical care, we have to test the utility and performance of biomarkers, and what is the validity of future biomarkers before implementing. So in early diagnosis of sepsis, it is important to initiate effective treatment. Then came yes new sepsis 3 criteria, and it's defined new sepsis 3 criteria, for sepsis 3 criteria before, and this modifying new sepsis 3 criteria, and it's defined sepsis and organ dysfunction caused by infections. Biomarkers can aid in diagnosis of infection and monitoring of organ dysfunction. So biomarkers is very easily diagnose of infection and monitor of organ dysfunction. How after a patient in sepsis, how our organ that organ in his body is working, and PCT, Preceptions, CD64, SUPAR, and STRM are the best evaluated marker. We know this. Performance of biomarkers should be tested clinically before use. So on the we know the best biomarker, ideal biomarker. Some biomarkers are weak. So performance should be done before any clinical use. So the performance of these biomarkers and kind of biomarkers like ideal biomarker or which one is best, it defines by the ROC curve. The ROC curve is most loud. So this ROC curve, by the ROC curve we can define these biomarkers, how is how the biomarkers is effective in our body or in sepsis. So by this ROC, we know the ROC curve is widely used tool for comparing diagnostic testing. So ROC curve constructed by plotting diagnostic sensitivity and specificity value. So every individual cut of on graph one specificity on x-axis and sensitivity and on y-axis. Shape of ROC curve and area under this curve estimate the discriminative power of biomarker. And closure curve, the curve when closer located left hand corner and larger AUC determine better marker discriminating between septic and non-septic patients. Perfect biomarker AUC and area under curve of 1, whereas non-discriminating marker has an area of 0.5. So we see by this curve, area under curve if area under curve of that biomarker is 1, that is very good biomarker, and 0.5 is the is not is non-discriminating marker. And by this we see the different kinds of biomarkers here. So super stream 1, this MIF, neutrophils, procalcitonin, CRP, and this 3 marker and 6 marker. We see the combinations of markers is a very good very good very good in diagnosis, like three biomarkers we combine or 6 biomarkers we combine, and this graph will show the how these 3 marker and 6 marker are effective. So with this ROC curve, we some comparing like some super. This is the super stream MIF. This is macrophage migration inhibitory factor, neutrophil count, procalcitonin, C-reactive protein. So 6 marker combination is the best performing marker model, and we see by this ROC curve area under curve is 0.88, and 6 this is near about to 1, and this is best performing marker model. And this combined 3 marker or 6 marker is of detection of bacterial or non-bacterial systemic inflammation. So we individually we studied about some biomarkers, like first is STRM1. This is soluble triggering receptor expressed on myeloid cells 1. So what is this? This is a glycoprotein of immunoglobulin superfamily and is specifically expressed on the surface of monocyte and macrophage and neutrophils. Mostly they are these biomarkers are on the surface of monocyte, macrophage and neutrophils. So its molecular weight is like TREM1 and is 30 kilodalton, and STREM is STREM myeloid cells is 17 kilodalton. So ligand is unknown. So engage with Dept 12, that is intracellular calcium ion mobilization and actin rearrangement. This is the activation transcription factor. The diagram we see here how these biomarker, this is stream biomarkers is working there. This stream 1 is it is soluble form and expressed at higher level into the blood and body fluid in the event of infection. This stream is when a person is infected, then it's very high level in the blood and body fluid. So we can see the if a person goes in infection, then by measuring the amount of biomarkers in body fluid and blood, we can evaluate the infection level. So studies show that patient with serum like STRM1 level of 129 picogram per ml or above had significantly poor prognosis. Because this is a soluble form, or this is higher in high level in blood and body fluid. So if the level is more than 129 picogram per ml, it's so that is significantly poor prognosis. Studies show also that key streams 1 level on diagnosis like of TB were significantly higher in non-survivor, as well as compared with 6 month survivor. Person non-survivor or 6 month survivor, this is mostly this biomarker is higher in non-survivor patient. Second, another biomarker is interleukin, interleukin 17. This is glycoprotein homodimer of 155 amino acids, and this is it is produced by a subset of activated CD4 plus CD4. This is T lymphocyte cells, and as well as some CD4 CD8 cells, and natural killer cells also produce this interleukin 17. This is a interleukin 17 gene on chromosomes. This is the location is 2q31. Its molecular weight is 22 kilodalton. Receptor interleukin 17 are secretion of interleukin 6, interleukin 8. This interleukin 17 helps in the secretion of interleukin 6 and interleukin 8. Interleukin 17 stimulates expression of AIIMS1 and PGE2 LIF, increased expression of AIIMS and COX2, and neutrophilia by expression of GCEF. So by the diagram we see here pro-inflammatory effect of interleukin 17. Here interleukin 70 some synergy with this interleukin give local inflammation and amplification of inflammatory response with hematopoietic growth factor. Here hematopoietic growth factor leads to expansion of myeloid lineage, monocyte and neutrophil recruitment. Some chemoattractant molecule like interleukin 8, MCP1 and ZRO alpha leads to induction of stimulatory molecules like ICAM and leads to T cell activation. So this interleukin 17 leads to different kinds of interleukin activation, and it leads to good prognosis of sepsis. So upregulation of interleukin 17 expression in T lymphocytes has been correlated with active TB, because we have see that in these interleukin 17 biomarker is a very good biomarker in a person suffering from TB. Some studies have showed lower level of interleukin 17 may play a role in predicting death in patients with pulmonary TB. If a person is suffering from pulmonary TB and he died, then by see this interleukin 17 we can predict that person is suffering from pulmonary TB. In another study, we second month of treatment, like interleukin 17 level were lower in non-survivor compared to survivor. So if a person is going on treatment, then second month or third month we measure the level of interleukin 17, and is mostly in non-survivor person it lower as compared to survivor. We can also predict the person interleukin 17, how interleukin 17 is useful in the diagnosis. And another biomarker is procalcitonin. Procalcitonin is a peptide consisting of 116 amino acid that is synthesized in the thyroid gland and by the leukocytes. This is calc1 gene on this on location chromosome 11. Molecularity is 14.5 kilodalton, and it's belong to calcitonin superfamily of peptide, which are three parts mostly by the diagram: N-pro-CT, immature procalcitonin, and catacalcin. This is the three parts. Procalcitonin made from these three parts. The level of procalcitonin rises in response to a pro-inflammatory stimulus, especially of bacterial origin. Means person is also infected like viral infection with bacterial infection. This procalcitonin, especially in bacterial infection, it rises. Use is mostly used in sepsis, pneumonia, chronic kidney disease. And procalcitonin can provide prognostic information and may be helpful in identifying patient having designated TB and as well in sepsis as well as in designated TB. Procalcitonin जो value is more or equal to 0.5 nanogram per ml, an independent mortality predictor among pulmonary tuberculosis. This we give here. I give here the example of this pulmonary TB. Pulmonary TB, the PCT level is more than 0.5 nanogram per ml. It's indicate the person is suffering from the TB. Another study evaluated the prognostic value of procalcitonin among pulmonary tuberculosis cases showed a significant high level in non-survivor compared to 6-month survivor. This also helps in survivor, non-survivor. Another biomarker like C-reactive protein, and this C-reactive CRP is widely used biomarkers nowadays, and it is an annular pentameric protein found in blood plasma. It is an acute phase protein of hepatic origin because it originates from liver. That increase following increases interleukin 6 secretion. This helps in interleukin 6 IL-6 secretion by the macrophage and T cells. Here we see them by the diagram also how this CRP helps to release interleukin 6, interleukin 1 and some other biomarkers. Member of this is CRP is a member of a small pentraxin family, and this is a 224 amino acid made up of 224 amino acid, and this monomer is a weight nearly 25 kilodalton. It's bind to lysophosphatidylcholine expressed on the surface of dead or dying cells and bacteria. CRP binds stimulatory receptors like this FcYRI and FcYRLLA, increasing phagocytosis and the release of inflammation cytokines and to the inhibitory receptors, blocking activating signals. And this CRP increase in inflammation, this coronary artery disease, autoimmune disease, and this obstructive sleep apnea and cancers. And it is a biomarker of inflammation. This CRP is a biomarker of inflammation and tissue injury and positively correlated with the degree of disease activity in sepsis. So some studies show that serum CRP level on diagnosis. I have given here the example of TB CRP, and as well after this CRP level in sepsis and as well as in diagnosis of TB were significant higher in non-survivor as compared to 6-month survivor. Its higher level in non-survivor compared with survivor also highlights its value as a useful tool in predicting the prognosis of patients with sepsis. So another biomarker is like Preceptions, CD14 subtype, act as a co-receptor for detection of bacterial lipopolysaccharide. It's activating a pro-inflammatory signaling cascade on contact in infectious agent. CD14 recognized molecule in the mostly in innate immune response against microorganism, and this perception says during inflammation plasma protease activity generate mostly soluble this CD14 fragments, and this CD fragments this perception is a perception biomarker is this CD4 fragments. This lot of fragments is there, like CD4 14, the this is combination of different kinds of CD 14, and from these combination given combinations in one is Preceptions, and these Preceptions have some limitations because of its no these biomarkers have some limitations because its biomarkers is time consuming. It's take time to give result, and it is non specific to etiologic agent because its biomarkers cannot define the which etiologic agent the person is infected, and these may not work in easily stages of infection. Different stage of infection it not working. Maybe like certain stage of disease in person is infection, these biomarkers is giving good result. So some recent also advanced recent studies and give some advanced recent advances biomarkers like microRNA, long non-coding RNA, and human microbiome. These are three recent biomarkers. Uh, some future sepsis biomarkers we have like TREM. This is triggering receptor expressed on myeloid cells, cytokines, and pentraxin 3. These three are future sepsis biomarker because these are not fully understood, and on these three biomarkers studies going. So biomarker, what is the biomarker combinations? Biomarker combinations, we use a single biomarker to diagnose sepsis, and if we combine these biomarkers and then use for diagnosing, then it is very useful. Like combinations of markers improves diagnosis, prognosis, and treatment efficacy. Combination of three we have already studied. Combination of three best performing biomarkers is more accurate in detecting inflammatory response. So inflammatory response, so if we combine some biomarkers, then it gives good result. Last conclusions, sepsis is the major cause of death in hospitalized patient. Mortality rate is very high, more than 60%. Hence is called is hidden public health disaster. And accurate and timely diagnosis of infection or monitoring of treatment are very important for patient diagnosis. Current evidence suggests that CRP and procalcitonin will remain the best marker uh, in diagnosis in sepsis and most commonly used nowadays. And some studies says this trend one is ideal sepsis marker because of giving accurate result, but this is not fully understood the mechanism of this TREM1. So nowadays this CRP and this procalcitonin biomarkers is very widely used. And why they are very widely used, these two biomarkers? Because of easily available in hospitals and labs, and it is less time consuming, easily done at any time, not expensive, affordable for uh, middle economic classes, and this good prognostic and diagnostic results. So these lot of biomarkers we have studied, but these two biomarkers is widely used due to this reason. Thank you. ये कौन है क्या